Welcome everyone, and really nice to see. I think at last look we've got about 73 people and myself and Tina on the call, so it's really nice to welcome you back. If you came to the last one, we last time we looked at fabricate. Oh no, we didn't. We looked at febrile convulsions. Today's session is a little bit more general. So we're going to be looking at assessing the unwell child and really thinking about those times when a child is unwell, but actually, so we're really focusing today on early years environments and also parents, those of you that look after children in the home environment. So those of you that are nannies and child carers. Everyone is welcome on the call. Definitely my Safe and Sound colleagues are all very welcome on the call, and I know some of you are here today. And actually, last time we had some nursing students on the call. So really just to say right from the outset, this is not meant as to be overwhelmed with science. It's not really meant for medical professionals. So just to sort of understand that this is really targeted at those of you who are looking after children, or as I said, those of you who are parents. And really what I want to do today is to go through and unpick a little bit about understanding what is normal childhood illness. Children will get unwell, and they do get unwell quickly, they get unwell often, but most of the times they get better by themselves and they get better quite quickly. Well, we have those times when we're thinking, do I need to be a little bit more worried? And particularly from an early years perspective, you have those times where you've recognised that a child is unwell and maybe you've called a parent to come and collect them, but they're working and they're going to be an hour and a half. Actually, what are the things that would say to you, no, I need to pay a little bit more attention to this, and maybe I need to call for help, maybe I need to call an ambulance, maybe I need to get a paramedic to assess the child, or am I happy to let the wait? The same as when you're a parent at home, how do you know if you need to be a little bit more concerned? And then at the end, we're also going to touch on actually what do you do if you've seen someone, you know your child's unwell. We might have even given you a diagnosis, but you're a little bit more worried, and when do you go back for more help and when should you be alarmed? One of the things I should have said at the beginning, those of you who were here last time will be aware. So my background, just very quickly, is I'm an adult and a paediatric nurse. I qualified in both, well, adult over 30 years ago, child a little less, about 27. With mainly my background is in emergency care. And probably about 20 years ago now, I completed my master's in advanced paediatric practice. And I continue to work in environments where I see and assess children, either for minor injuries, minor ailments, urgent care settings, those sort of environments. So as Tina said at the beginning, there is a Q&A. One of the comments last time was that actually it was quite hard to understand what the question was. Sorry, I didn't realise everyone couldn't see them. So just to make it aware that the Q&A, if you write a question in the Q&A, everyone will be able to see it, but there is the option to be anonymous. And what we'll do is I'll come to those. So I'm going to plan to chat to you for about 30, 35, maybe 40 minutes, not any more than that, and then we'll get on to the questions. Okay. So one of the things that so there's a few take homes for me always with these sort of sessions, and one of the things to try and get you to think about and maybe to visualize, and then I'm going to talk through some of the objective signs and then some of the very few more subjective, the things you can measure. But try and recognize a childhood illness almost a bit like a roller coaster. That's a normal trajectory of illness. And what I mean by that is there will be times when your child is down and your child is quite flat and really a little bit unwell, and maybe you're feeling a little bit anxious, but then they pick up and then they drop and then they pick up. And that's the normal, almost healthy, unhealthy pattern. So that's the normal, healthy, unwell pattern. Commonly, what tends to happen is they'll be on one of these lovely highs the minute you come to see someone in an A&E or at a doctor's, and one of the first things you're going to say is, I promise at home they were really unwell, or in the nursery they were really unwell. So one of the things I want you to think about is that actually most children who are unwell but managing it themselves respond to things like some cowpole that takes away some of the symptoms. They feel a little bit better and they feel a little bit livelier. But then as that wears off a bit, maybe as their temperature starts to rise again, they'll be quieter and they'll be more lethargic. But that's a normal pattern. Um, so we're going to try and unpick some of the things you can measure. So sadly, at the last session, and at some of the sessions coming up, there's a real structure, there's a real pattern that we can tell you what to do. So we talked about fitting last time, and there's a set of behaviours that you can follow when a child fits. Assessing the unwell child is a little harder because there could be so many things that are going on. And as I said, all children get unwell. So these are also situations that you need to manage. But what I'm going to try and give you is some tools, and we can, Tina will be able to give us some more information about how you do that. But this recording is available if anyone wants to. But also, I'm not precious about any of the information that I'm sharing, that it's all referenced at the end. But if there's anything here that's helpful to anyone, maybe to have in your nursery as a little tool or a little reminder, by all means contact us, and you're very welcome to any of the sort of ideas or guides if it helps you. So when you're trying to determine whether a child is really unwell, just a little bit unwell, do you need to be worried? There's three sort of tips that I can give you. So the first two are quite objective. So that's thinking about appearance and behaviour, and we're going to unpick those. And then we've got a few signs that even if you are not medical, you can measure. So the things that we can look at to see actually how their body's responding. So what I want you to ask yourself, and we'll look at all of these in a bit more detail, what do they look like? What are they doing? And how is their body responding to that? So I might be worried and I might think, oh, they're really poorly, but actually is their body giving us any signs that can help to tell you to be worried? Because one of the things that again I'd say going through is it's so hard nowadays because we have access to the internet, and the internet is a fabulous thing, but it has scary information as much as it has helpful information. Social media is wonderful, and for those of you that, like myself, it was a long time ago for me, but I've been a new parent. Social media is the most perfect thing to reach out to when you're struggling and you want a little group of friends to give you some advice. But there's also some really, really bad advice and information that's out there, and that can throw us off. TV will flag correctly the very rare cases where things go wrong, and so that makes us scared when children are unwell. So we're going to try and look at these three stages. So that first one, what do they look like? And there's a couple of the symptoms here. I'll pull them out as we go through, that I'm going to unpick a little bit more at the end. But if there's any of these words that I haven't broken down for you, that you're not sure what I mean, do put, like, take a note of them now and do put that in the Q&A. So our first one is, how alert are they? And alert doesn't mean that I'm lying around and I'm being a bit more quiet than my usual self. So I'm feeling poorly. Think about the last time you all felt unwell. I want to lie around in bed a bit more. I want to lie on the sofa a bit more. I want to watch a bit more telly. However, how responsive am I in that? A good example for you in a nursery setting would be someone different comes into the room. Is the child still interested in them? Do they still look? So their favourite carer from a different room. So let's say you've got a child that's in, it's a long time since my child was at early years, but they've progressed out of the baby room. You've now got someone who's in the toddler room, and the word spread that they're not feeling very well, and you're all a little bit worried about them. And someone from the baby room that this child knew really well has come into the room, and they get on really well. They like this person. Are they looking at them? Are they interested? Do they still respond to them? If they didn't, that would be something that should flag to you as, okay, that's a bit unusual. That's not, they're not as well as normal. X has come in the room. A home example would be, your child's been at home, they're not feeling very well, they're lying on the sofa, they're much quieter than their normal self. Their older sibling returns from school. Normally, most unwell children will still perk up a little bit. Parent returns home from work, perk up a little bit. A grandparent comes around to visit, they'll get a response. Children that don't get a response, that would be something that I would want you to be a little bit more concerned about. So these are just generally how you assess, and then we're going to look at some of the red flags. Let's have a little think about their skin colour. Now, you all have a privilege that I don't have when I'm assessing children. I have to trust the parent because I've never met this child before. I have no idea whether they're normally flushed like this, whether they're pale for their normal. Have they got deeper shadows under their eyes, or is this a child who's never sleeps and always looks a little bit dark-eyed? So you look, and is there something that looks different about their colour? Are they just a little bit paler? Or do you think they were even more pale than they were this morning? And is that increasing? Flushed might just help us to say that possibly we've got a temperature. One of the really important signs for you to look for in skin colour is mottling, but I'm going to show you some pictures of mottling in a second. And then I've talked about that sort of darkness, shadows around their eyes. Posture is really, really helpful, especially in the little ones, especially in the under one. So are they sitting upright and comfortable? Are they strong in their posture? Or are they looking a bit floppy, and are they looking a bit slumped? Think about your babies. Those of you that have done our first aid, paediatric first aid courses, we often talk about this quite a lot. Big, heavy heads. If I'm a baby, my head is about a third. So if I'm 6 months old, my head's about a third of my total body weight. If you just picture in your head for a moment, now you can only see my head and shoulders, but my head, you could fit quite a number of heads in my whole body. But in a small child, that is proportionately, my head is much bigger. It's a large, bony, heavy object. So actually, am I now feeling tired and I'm struggling to hold my head up? Or am I still holding my posture well? These are all things that can just start to give you a clue that no, actually they are more unwell than they normally look. Behavior is the absolute best measure of how well a child is. This would be the thing that I drum into every junior doctor on rotation coming to paediatrics for the first time. What is that child doing? How are they behaving? So one of those first things, and again, this is goes across the age range, but are they irritable? Again, think about the last time you were unwell. My 20-year-old is not feeling great at the moment. He's grumpy. He's not irritable. His behaviour is still normal. He's just a bit grumpy. Um, Actually, is this a child who really isn't consolable in any way? An example I would always give here is I wasn't, and I'm sure all of you are going to be far better. I wasn't one of those mums who could say with a newborn, even as a children's nurse, oh, that is the cry that means they need some food, or that's the cry that means their nappy needs to be changed, or that's the cry that says, please, can I go to sleep? Generally, those three cries, I would know that they were hungry because they hadn't been fed for a period of time, or they probably needed to be changed because they had been fed and they had slept. But the cry of pain is a very, very different cry to any proper, true cry from irritability, is a cry that's really different to anything you've heard before. The sort of noise that actually, when I work in A&E and I can walk through the department, I'll be able to say, okay, that's a cry that concerns me. Who's that child? What's that baby? What are we doing for them? What have they come in with? So if there's something different in what you're hearing, that's a really good clue to say to you, okay, this might be a bit worse than normal. Actually, I can't, everything I've tried, I cannot settle her. Now, we'll also always know that there are some small babies who are really, really hard to settle, but it is generally a good rule. That is, I can't console this baby. There's nothing I can do. They are just crying. Then actually they probably do need to be checked. Or this is usually a really easy to settle baby and they are just so much more distressed than normal. I've tried some Calpol and they've still not settled. So just have a little think about that. How irritable are they? If we go to the older child, it's again things that are probably, wouldn't want to go as far as the word irrational, but just harder to console or settle. They're properly annoyed and irritable, but in a more unusual manner to their normal behaviour. So now have a look at what they're doing. So a child who plays for a little bit and then goes back to lie on the sofa, does a little bit of drawing, doesn't last anywhere near as long as they normally would in those activities, but they're still interested. They're still wanting to do it. You can distract them for a little while with a game or a toy or a bit of TV, maybe something on your phone if we're talking parents. Is there ways that you can distract them? That's a normal unwell child. A child who actually you really can't distract at all should be something that's worrying you a little bit more. Now I'm going to slightly distract and not at all a soapbox, but I've got a lovely audience and it's really important to get this message across. So whenever a child complains of pain, one of the first things you want to know is it pain that goes away with gentle analgesia? Can you give them a gentle painkiller, paracetamol, Nurofen, and it gets better? It might not go away, and if it doesn't go away, that might well be something that you know and you think, okay, I'm going to go and get them some help. But while we're on that, it's really, really important that children who are in pain are given pain relief by the people that are caring for them. I, without question, see a child in emergency care every single shift. Unusual to only see one who presents having come in, who is in pain and who hasn't been given any pain relief. And the main reason, it's not because anyone's cruel or horrible, the main reason people don't do that is that they're really worried that if they give them something for pain, that it might take away the pain and mask it, and then we won't see what they're seeing. There is no pain relief that you can give out over the counter that's going to completely take away a problem. And actually what it does do is it helps to give us a much better picture. So just while I've got a captive audience, really, 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 really encourage people. I mean, I saw a child yesterday with a clearly broken wrist who hadn't been given any pain relief because the parent really didn't want us to not see that they were in pain. And as I say, there was no cruelty in that, but it's something that's really, really important that we stop doing. So have you given them some pain relief? You've got a 4-year-old who said they've got a headache. You've given them some paracetamol, so some Calpol. Has it helped? Now, to be careful, advertising Calpol, it can be paracetamol from any brand. And then that very last bit is, what are they interested in? So one of the things to think about is, what do we do in our normal day? So if I was teaching this to a clinicians group, I was teaching this to colleagues, particularly adult focused colleagues, I would get them to think about what we call the normal daily activities of daily living. So for a child, their purpose in life is to sleep, to eat and drink, to play and to socialise, and then elimination. So the sort of things we're thinking about is, are they still wanting to eat and drink? And if not, how much? Are they just picking out a bit of food, but we can still get them to drink? We'll talk about fluid intake in a second. Are they still wanting to join in activities, or are they not interested in anything at all? And how much disruption or how much increased sleep have we got? Okay, so the last thing in that little triangle, the third corner, was saying, is there anything that you could potentially measure at home? So this is always harder, because obviously you know that if you come to hospital, there's a lot more things that we can test. But these are just the things that you can measure that are really good signs and symptoms to say, actually, maybe my child is a little bit more unwell. Now, if you came to the last one, you will know that I don't think temperatures alone are very helpful. Children get hot, and if you joined us last time, we talked about the fact that the part of your brain that controls your temperature doesn't develop until you're about 5 or 6. So it's normal for children to have temperatures. But at least you will know when you're putting this picture together, okay, well, they've got a temperature, they're a little bit unhappy, They're a little bit quieter than normal. Their behaviour's not quite their normal, but I'm seeing that nice roller coaster. Give them some cowpole, they perk up, they're interested in what's going on, they're playing, they're drinking a little bit, but then they become quieter as that wears off. And then we have a period of where they're lolling on the sofa, but now we've given some Nurofen this time or whatever's happened and we've perked back up. So it does still tell you that, okay, there's something going on. They're not quite right because we've got a temperature. And can I manage it? Is it going up and down? Breathing is a really, really good one. And we'll come on to talk about this a little bit more. Do you think they're breathing more than normal? And is their breathing different? Now, my one big tip from today, particularly for those of you that are in a child caring environment, um, so an early years environment particularly, are are you consciously looking at how children are breathing? And if not, just over the next couple of days, just do it. Look at normal breathing. So have a little look when you next are changing um, under one on a changing mat, and so their clothes are unpoppered. Have a little look at their chest and have a little look at their tummy, and have a look at how much they move. What you'll notice is that the tummy dips in and out as they move, but it shouldn't dip and tuck under the ribs. You shouldn't really be able to see the ribs tucking in and out, definitely not in an under one because they usually got a little bit of tubbiness on them. As a child gets a bit older, you may well see their ribs, but again, you shouldn't see as they breathe, their ribs shouldn't become more prominent and less prominent. And they will continue to use the muscles of their tummies, but they shouldn't be using them a lot. So one of the things that's a really helpful thing that tells us, okay, this child's breathing faster than normal. That's something to pay attention to. There's many reasons why we breathe faster, but they're usually associated with being a little bit more unwell. So our breathing rate increases maybe to compensate for needing a bit more oxygen, maybe because you've got a problem with your respiration, but it's a really good clue all the way across. No really unwell child will have a normal breathing pattern. Now, it is hard. I mean, I can give you the rates, but if we talked about a 1 year old, their breathing rate could be anything, sorry, a 0 to 3 month could be anything between 30 and 60 breaths in a minute. A 6 to 12 month old could be anything between about 30 and 50 breaths a minute. So that doesn't really help you very much because it's a wide spectrum. But one of the things I would say, particularly again, now if I flip to parents for a second, parents watch their children sleep more than you give yourselves credit for. You listen to them. Those that you care for, you listen. You've got all of these natural inbuilt clues. It's just knowing what to hone into. So just take a moment and just listen. Listen to their breathing. Are you hearing noises that you don't normally hear? Does it sound more rapid than it normally does? Looking at them, are they working harder? So breathing rate is a really good clue. Do you think they're breathing more than they normally do, faster than they normally do, or are they putting a lot more effort into that breathing? So my little challenge for those of you that are not sure if you would know that or not, just start having a little look at some of the children that you care for or your own children. Fluid in, fluid out, nice, simple, easy to measure. So we worry a lot that children are drinking less. It doesn't have to be copious amounts, particularly if they're feeling sick. Small, little and often, but are they still interested in drinking? Food can go on the back burner. Food can be just picked at, but we do need to maintain our fluid input to keep ourselves healthy. So a child who's not drinking at all would worry us and we would want to see them. But actually the best measure of how much they're drinking, are they drinking enough, is it coming out the other end? So what you really need to look at is, am I seeing a lot less wet nappies? Are they going to the toilet less? Are they using the potty less? So they're things that you can really measure. Actually, when was the last time that this child had a wee? And can I increase their fluids? Okay, so we've got a few red flags, and then we're just going to unpick a couple of those signs and symptoms, and then we can have questions. So, babies for the moment, the real red flags, floppy. This is, so I talked at the beginning about posture. This is a child who is struggling to have the energy to hold their head up in a normal position, um, to hold their shoulders. I should probably have said at the beginning that in the first 6 to 12 weeks, definitely 12 weeks, babies are really difficult for you to assess. If you think a baby who is under 12 weeks is unwell, then you should really always get some medical attention and just assess whether you think whether someone thinks that they're unwell. It doesn't necessarily mean you need to rush somewhere, but under 12 weeks, we don't tend to just say, let's manage that at home. So we've now got a baby who's very lethargic. We're going to look at lethargy in a second, but that's really just difficult to wake, really sleepy, often linked together with that floppiness. Back to that irritability I said. So this sort of flag is particularly the ones that I want you to think about. Should I be calling an ambulance? And there's a couple where you definitely should, but should I be calling an ambulance? But probably all of this slide, this is a child that you've recognised is unwell. You're in a nursery setting, and the parent has said, I'm going to be an hour and a half. These are the sort of groups of children that I want you to really carefully think about. Actually, I don't think we can wait an hour and a half. I want to call someone to at least assess them now. I'm going to tell the parent that actually I want someone to see them now. So that irritable crying, that crying that you just cannot console, or to all of you says this is different. I think harder as a parent on your own, especially a new parent, a group in a nursery, if a cry is bothering a few of you, it's really a sound that's making you all think, "Oh, that just doesn't sound right." Trust your gut and your instinct. Mottled skin, we're going to talk about in a second, so just hold that thought, but it's definitely one that I want you to pay attention to and respond to. Difficulty in breathing, so once a child starts using their tummy much more, and actually you're seeing real proper movement in that breathing. And then the last one, this is the only one on this slide that doesn't necessarily need you to call an ambulance, but definitely is the sort of thing that you should respond to. That's your child at home where you've been managing them, but actually this is the point where now I want someone to see them. And can I see my GP today? Great. But if I can't, then I might think about taking them to an A&E or a walk-in centre. And this is a child who you can't get to drink at all, who you're really not seeing a normal urine output, or actually you've really got to very minimal urine output. That should be a real red flag for you. So just quickly look at those for an older child. They're very similar. So the lethargy that we've talked about, and we'll have a slide on that in a second. That difficulty in breathing still, so that carries on, and that really carries on all the way into school age children, but you just see it a lot less. So definitely in the preschool age, that working much harder. Think about that mottling in a second. And then we get to the fluid input and output again. So are they vomiting a lot? Are you struggling to get them to keep fluid in? And are you seeing very little wee coming out? Now, the one that you've probably heard about quite a lot, and is a really good one to just very quickly unpick, is that dislike of lights that comes with a severe headache. Now, children get headaches more commonly than probably most people realise. Temperatures often cause a frontal headache, definitely in preschool, early school age children. And so your child's woken from a sleep, and you've brought them into a bright environment, and suddenly they're not liking it. If you think about yourself when you've got a cracking headache, actually nobody wants to be in a well-lit area. That's not necessarily true photophobia, and that's what we're looking for. The test I'd get you all to use, which is really, really useful, is the TV test, the TV or the phone test. So especially if a child has been in a dark environment and you're suddenly bringing them into a light, bright environment, they're not going to like that. We want them to adjust to it quite quickly, but if they're struggling to adjust and you're worried, dim the lights again, but put on a bright light source. So that the best one for that is a TV or your phone. If the child can look at a TV or the phone, did those the wrong way around, but the TV or the phone, then the reaction to their pupils will still be there and will be the response. The reason we're worried about what we call photophobia is because as our pupils dilate or they constrict, it triggers it triggers our optic nerve, but it triggers one of the cranial nerves that are affected by the meninges that go around the brain. So you probably know that this one is one that's associated with meningitis. If we get the child to look at a TV or a bright light, computer screen, a phone screen, the same thing happens to their eyes. If they can do that and they're not worried, then you can be quite comfortable that they're not having that positive bright light reaction. But bringing most children, especially one that's been sleeping, into a bright environment will often get the reaction of that's too bright. So dim the lights down, but then do the TV test. And then I quickly just want to go through, and I don't know if you'll be able to see this, let's try. Thinking about that rash that doesn't go away with light. In fact, I've got a picture of it, so we'll hold on for a second. So these again are the things that should make you think quite quickly for children, and probably all of those are ones that would indicate that you need some more help. Again, it's not as simple with this, I'm afraid, of saying you've definitely got to call an ambulance, but all of those would warrant actually the child needing to be seen in A&E. Whether that means you're going to take them or whether that means you're going to call an ambulance will depend on the environment, who you are, where you are, and how concerned you are. So let's just unpick those three signs. I'm nearly there. So lethargy. Lethargy is that state where a child just isn't interested in anything. This is that one where they're not really responding to you or what you do. You could see a child almost that sort of where they're not really engaging in the environment. So that's staring straight forward, staring straight through you, staring straight past you, activity going on around them, and they're not looking around at it. They're just carrying on looking. Not really moving much, struggling to look up, lift their head, and maybe in an older child, it's being more sleepy. So that's truly lethargic. The child who's just dozing on the sofa, you can easily wake them. They watch a bit of telly, have a bit of play, they doze on the sofa again, they get up and repeat. That's not the same. Lethargy is this where you really can't, you're not getting the roller coaster, you're just staying down in the dip. So mottling. So the picture in the middle, hopefully that's showing quite well on the screen. That's probably harder if you're looking on your phone. So mottling can happen for a number of reasons, and it can happen to our lower limbs. And many of you might have seen it in your lower limbs to a child who's got a temperature. Mottling is a sign that potentially your fluid is not circulating as well as it should be, either because it's in the wrong places or because there's not enough fluid. So it does happen to the lower legs when our temperature increases and naturally the body reduces the blood flow to the arms and the legs because they've got nothing important in them. There's no key organs there, and it holds it centrally. That's not necessarily so worrying, but I think if you see it, it's still worthy of being reviewed. We would never worry about someone who presented to A&E with mottling of the lower limb. So I think the best message I can give you from this session is to always be aware of it and know that that's a little bit more worrying. Mottling to the body is very worrying, and I would always want you to present your child. This is one of those signs where I would say this is definitely relevant that you bring someone into hospital or call an ambulance. Again, we've got to look at that whole picture. So is this in a child? You can see mottling, but the child is more alert, then I would be less worrying than mottling and quiet. And now we're thinking we haven't had any urine output for a while, and we've got a child who's irritable or hard to console. So it's about putting a picture together. So this mottling is this irregular pattern to the skin. It looks like a marbling, I think, is the best description that most of us would be familiar with. We used to refer to it sort of corned beef, but I don't think anyone eats corned beef anymore, so probably don't know what it looks like. It's that sort of net-like. Now that picture is obviously on white skin, and that's where you can sort of see the red patches if this is on darker skin. So darker skin tones are more likely that those lines are more bluish, purpler, but you'll still get the paler patches and then the irregular pattern. If you are trying to look at this on darker pigmented skin and it's hard to see, then it's often helpful to look at the forearms, even up towards the armpit or onto the palms, where often this will show a little bit better. So our last couple of things just to unpick. Now, everyone's aware of the glass test. I think we've publicised this really, really well, but it's really helpful to just understand what you're testing. So what we're looking here for is what we call a non-blanching or a petechial rash. And this is when the capillaries, so the very, very smallest vessels that we have, the ones that come to the closest to the surface of the skin, pop and bleed, and we have small little bleeds under the skin. So when we push the blood out of the capillary, and I'll try and show it, no, I'm not sure it's going to work, but you can do it yourself just looking at your own fingers now. If you press the blood in the tip of your finger should have been well perfused. You release it, it's much paler. So on my skin, it will be nice and red. I press it, it goes white, but then it goes red very quickly. And all I'm doing is moving the blood out of the capillaries and watching how quickly they refill again. So if they're all working nicely and I've got no bleeding there, I shouldn't be able to see them. So what we're aiming to do when we push with the glass, and sorry, because of the safe and sound background, that's not working well, is it? But when you're pushing on the glass, you're pushing the blood out of that capillary. So you do want to press down quite firmly. You want to look for the rash to disappear. And then as you release it, the blood refills. That's a normal rash. If it doesn't go away, then we want someone to look at that. And that's, again, something that if you put it together with the whole picture of a child who doesn't look very well, we need to respond quite quickly to. And so my very last bit is just thinking about, okay, my child's unwell, or this child is unwell. I think this is probably more for parents, because if the child is or parents or nannies, in-home carers, the sort of person who is going to have a child who we know is already unwell with them. So hopefully this isn't in a nursery type of environment. But you've got a child, and let's say they've already gone to whoever, a medical professional, and they've assessed them. And they've said, yep, we think that this is a viral illness. Carry on doing what you're doing. Give them fluids. Give them gentle antipyretics for their temperature or for the pain for the headache they've got. Keep watching them. Keep them well hydrated. Keep them cool. Let them rest, and they should be better. They should get better. The really, really important thing to say, and this is probably my thing as a healthcare professional, is whenever we see someone, we're looking at that child in that snapshot of time. And in that moment, that's how they were. There's nothing that can be, that we haven't got a crystal ball. We don't know what's coming next. So if something changes, trust your instincts. If you feel that the child isn't getting better, then there is you're not even asking for a second opinion. What you're doing is saying, I'm still worried. Will you see my child again? Never, ever, ever feel scared or apologetic about wanting your child to be seen again. But also, one of the things that's really good to do, and this shouldn't be your responsibility, this should be the responsibility of the healthcare professional. But if they haven't done that naturally, there's a time pressure, they've gone quickly, just haven't done that naturally. What you want to do is say, what should I be? I'm fine to take the child home now, but what should I be looking for? And what should make me bring them back? So this is called safety netting. This is our job to do this. So if I just gave an example of a little girl I'd seen yesterday, what her mum was really worried about was that she'd been vomiting a lot and she was dehydrated. So I talked through her behaviour and why I was happy with her behaviour. Actually, for her, what we talked about was just that little press of the finger, and I went through it with her really quickly just to show her how well hydrated her fingertips were, which suggested how well hydrated the rest of her body was. We talked about urine output, and so I gave her a list of 2 or 3 things that if that changed, I would want to see her back again, or I'd want her to go and see a colleague. So when you take someone home from, if you're feeling anxious about looking at them, never ever feel at all concerned about saying, not a problem, but what should be my red flags? What is it that makes you happy about them now? And therefore, what should I be worried about if it changes? And that should be something that we're really, really happy to share with you. Okay, so we're going to go to the questions just for any, so that people know there are some references at the end that people can go back to. But if you bear with me for a second, I'm going to stop sharing. So we've got lots in the Q&A already. So I'm going to bring them up. I thought they'd all be anonymous. Okay, so what's the best thing to do when the forehead? Okay, so the first question, I think everyone can see them, but I did promise that I would actually read them out this time. So this one is, what's the best thing to do when the forehead thermometer keeps showing different temperatures, for example, 41.2 to then 36.8? So that's a great question, but what it really does show is the challenging accuracy of forehead thermometers. So I don't know whether this is from a nursery setting or whether this is from a home setting. If this is a parent question, what I would say is, sadly, I think invest in a different sort of thermometer. Probably the most easy one for most of you to use is a tympanic thermometer, which goes in the ear, and I'm fairly sure you can get those nowadays for fairly reasonable, sort of 20-ish pounds type of range. But that is a quite hard question, but what that's showing you is their inaccuracies. However, what I would also say is that the likelihood is that the higher temperatures are probably right, because it's got to respond and pick up that heat range. So I probably would, I mean, I don't know, again, sorry, the one thing that's challenging with the Q&A, and by all means add some more comments in if you do. That I didn't see the next one, which also says, if you only have a forehead thermometer, which is the best place to take it? It is the middle of the foot. So is it in the middle of the forehead, or is it the temples? Again, I would look at whatever your manufacturer says, because there probably is one on the market that is designed for the temples, but it is generally the forehead is where it is recommended on most of them. But yeah, that's difficult. Now I love these questions that tell me how many loose nappies should a child get sent? So I'm thinking that how many loose nappies should be the trigger for you to send a child home. And again, that's quite a hard question from a medical perspective, as in the loose nap. I guess your question is infection risk versus whether they are unwell. If I answer it first from the how unwell is loose nappies showing, how helpful is loose nappies as a sign and symptom of being unwell alone, it means very little. So we can have things that cause loose nappies that feature in a child who's not particularly unwell, and we could have very loose nappies in a child who's also not drinking, also not weeing. One of the challenges with loose nappies is it's really hard to then see how much they are weeing. But so such a hard one to answer it. I mean, yes, I would be starting to be concerned but I'm imagining all of your different organizations would have different policies. I think if you are having, and again, loose nappies in a child who has eaten something is weaning and is having new foods being introduced to them. So there's probably too many different parameters within that. I think if your organizational policy is 3 loose nappies and they have to go home, that's probably fairly reasonable for an infection control risk. If that doesn't really answer that one, ping us a little message, and I can have a little chat with an infection control colleague to see what they would suggest as their line. It doesn't necessarily give you I mean, there's so many reasons for loose nappies. So it's loose nappies and how well is the child in themselves. Sorry, I feel like I haven't answered that one so well. Lovely. So, sorry, not lovely at all for you, Caitlin. So my son's currently poorly and his skin always gets very mottled. His fingernails go purple. I assume this is to do with oxygen. It is to do with circulation, yes. So it's not so much just oxygen, it's that. So he will be, so my question for you first, Caitlin, is if does is this problem how he presents mainly in his the lower ends of his arms and his legs? If he does, and it also coincides with when his temperature is high, so generally as a child's temperature goes higher, this is this bit where I said before that the body naturally shuts down the vessels to the areas that have blood that we don't need it so much and pulls it more centrally. And it's a good protective natural mechanism to ensure that his heart and his lungs and all of his vital organs are getting maximum oxygenation and maximum blood. So if it just happens as his temperature goes up, and it's really only happening in his distal arms and his distant legs, but his little hot body in the middle. I don't know how old your son is. Then that in itself isn't so worrying, especially if as his temperature goes down, his hands and the mottling goes away, and his colour returns back to his fingers. So again, I don't know if I've answered that particularly, but you're exactly right. That's exactly what it is. And it's a normal response to temperature. So again, what I would say with you for that, because also what I don't want to do is reassure you never to worry, but you're quite right. If I've just said a moment ago, mottling should worry you. You can't rush your child in every time they're slightly unwell because this is something, I mean, some children even do this when they go swimming or and get very cold. So the same sort of mechanism happens when you get very, very cold. So the things I would think with that is look at how he is in himself, go back to all of those other things. How's he behaving? What's he doing? How is he generally in himself? But particularly, do you see this pattern in his skin when he's hot? But then as his temperature comes down, it settles. That's a really normal response. If you're seeing something more, then I would be a little bit more worried. Hopefully that has answered that. What is quite hard is I don't know whether it does answer. Uh, so I missed what you said about the part of the brain not developed until 6. Yes, so absolutely. So really good question. And Elaine, Tina will be able to tell you how to watch it, but the first session was on temperatures and febrile convulsions, so you might want to go back and watch that. But absolutely, what we covered in that is that the part of the brain that controls our temperature. So if we think about ourselves, it's the part of the brain that triggers. So the hypothalamus is what triggers. Tina's typing away. Triggers us to sweat or to get goosebumps. Isn't mature until a child is around 5 to 6 years of age. So it's exactly why younger children spike really. I mean, to find an adult that had a temperature of 40, 41 is really very unusual, and it means that person is incredibly unwell. To find a child who's got a temperature of 39, 40, 41 even is not uncommon, and it's exactly for that reason. Children will have temperatures often, and so again, one of the things we talked about quite a lot at the last session was temperature alone is not a great measure of how unwell someone is. At my setting, we have a no cowpox policy, so we can't measure it. What episodes don't. So that is a really, so that question was that you're not allowed to use cowpox in your environment, which is absolutely fine if that's the policy. So what's the next steps? If a parent can't come straight away. So the one thing to say, the Calpol is not stopping them being more unwell. The Calpol is just relieving a symptom and potentially making it easier for you to assess. But all of those things so that whole thing that I also said about Calpol not being super powerful and being able to make severe illness go away or mask it. So the most important thing for you to be reassured about is that Calpol doesn't fix very much. It just helps some of those symptoms go away. So you still stick to exactly those things that I said before on that slide. So your child will probably feel more rotten because you can't give them Calpol. They're less likely to jump up and start playing, so have that really, really good roller coaster. They're less likely to have that sort of response, but they still should care when someone comes, probably be more cuddly, but be appropriate. Someone passes them a toy, know what to do with it. They should still be drinking sips of water. You can still look at their breathing and you can still look at their skin. So all of those things I gave you on the red flag, so whether it was in the babies or whether it was for the younger children, those all still absolutely stand, even if you can't have cowpole. You've probably just got someone who feels more unwell. I'm not going to read that one out. But Alan, I'm with you, 20, nearly 22. That doesn't, just for all the parents on the call that think the little ones are the hardest, as Alan and I are verifying, they are just as difficult. And I have had texts all week of, Mum, I've got this. I'm a child learning to have a child, age 1, has heart murmur. Okay, so this question is probably a little bit more complicated for going into in this, but there are definitely things that so your thing was, I look after a child who has an heart murmur. There's a variety of things with regard to heart murmurs. You can have everything from an innocent heart murmur right through to a problematic one. So one of the first things I would say for you there is that you need to have a conversation with that child's parents and ask who they've been seen by. Have they been seen by a paediatrician or a cardiologist? Or is this just something that has been identified by the GP, so this heart murmur? And are there any specific signs for them? So children who have cardiac problems may well have signs such as, it's very rare to see that classic cyanosis in child, which is the change in the blueness in the lips, but someone who has a heart condition, oxygen might drop lower than other people, so you might have specific things. But what I would say is heart problems in children also present with breathing problems. So take that little note that I said to you before about being really confident in how they breathe. That little one that you look after at 1, be really, really confident in what their normal breathing looks like. You can make it into a bit of a game. So when you next, so 1 probably is still in nappies, depends where they are in the age of 1 and how well they're moving off. But have a little look at their chest, have a little look at their tummy. When they're next sleeping, listen to them breathing, and see how just become really familiar with it. Because if your child who has got any sort of heart problem starts to become unwell, one of the first things that you will notice is a change to their breathing, that it's more effort in their breathing. So that's a really good tip for you to look for that one. But I would also say to that parent, be really, really blunt. Have no problem with having your child here who's got a heart murmur, but can you tell me, is there anything specific that you've been told? Because there's a range of reasons that could be. I'm quite happy to, if that doesn't really answer it, I'm quite happy to answer a little bit more out of the call. But I think you need to go back and ask specifically what have they been told for that child. So there's a question there about a copy of the session for tonight. Tina will be able to answer that. I don't know if Tina can type in the answer to there. Oh, what's happened to them? I've lost the Q&A. Mine has just frozen. Tina, are you still there? Are you able to hear me?
Hi, Amy. Yes, I
Can
can
you
see
see
the
if there's any
Q&A.
more? Sorry, my Q&A has just vanished.
After, do you get a copy?
So yeah, we had, do you get a copy? And then there was a thank you note. Is there any
Yes.
other questions I haven't
Yes.
answered?
Is it bad when a parent constantly gives a child Calpol?
Oh, really? That's a good question. And so again, it's quite hard. Some of these are always hard without a true context. So, and I probably would be what your definition of constant was and what my definition of constant was. So Calpol is still, I'm worried that I might just suddenly disappear. So let's hope I don't. If there is a problem, Tina, tell me, because my screen is doing one of those lovely whirly things. Oh, I think I've got everyone back. Sorry about that for everyone. So constant really depends on how frequently. So Calpol is still eliminated through the liver. So paracetamol is still excreted through the liver. Any medication permanently is not great unless it's prescribed for you. If you mean that this parent has a low threshold to when their child's got a symptom, then I'd probably say no, it's not bad. It would be about what are they giving it for? So do they think their child is in pain? Do they think their child has a temperature and therefore they give it? Um, but it's also about making sure that the parent isn't giving it and not seeking help to try and find out why their child is often in pain or does often have a temperature. So I'm not sure I've really answered that because I think constantly is a bit of a hard question. Yes, it's bad if you're giving it for absolutely no reason. Do I think it's bad for a parent to give it because the child is teething and then 2 weeks later they've got a temperature and then 2 weeks later they've fallen and hurt themselves and they're in pain? Then no. Is there a good reason why they've given it? No, I don't think it's bad. If a child needs Calpol in a setting who is under two, should they be sent home? Again, really good question. And that will depend on your policy, and it will depend on why you're giving it to them. So a child who needs Calpol because they've got a temperature obviously is unwell, but fevers can come for a wide variety of reasons. I think no one personally, I would say no, not once. If they respond to the Calpol, they're much, much better. They're behaving normally, they're playing, they're doing all normal activities, then absolutely not. Your policy might well be that any child who needs to have Calpol has to go home, but from a medical perspective, there's absolutely no reason to think that they're necessarily infectious. And do they respond to the Calpol? Are they then well? Uh, we have a child with chronic ear infection. The parent doesn't want any antibiotics. She's a nurse. It's really smelly and it leaks daily. Any advice? It probably shouldn't be smelly and leaks daily, but she's also probably very correct in that the majority of chronic ear infections aren't necessarily bacterial, although smelling is slightly more concerning. All you can do with that one, so I'm guessing that question is as a healthcare provider, um, all you can do. So this is where, again, without talking to you specifically and getting more details, um, the parent is with, as long as the parent is seeking medical advice, and is making an informed decision to not have antibiotics. There's a lot of risk to having regular antibiotics. This is a chronic ear infection, so she's got lots of good reasons why she may not want to have, for her child to constantly have antibiotics. There's actually very little evidence base that suggests that would help. My concern would be, this is one of those questions. We had one of these actually on the last one. You've really got to answer this from a safeguarding perspective. Are you comfortable that that person is seeking health advice, and is responding to that health advice? I guess as a healthcare, if you were really that worried as a nursery, you could ask for some verification that the child is well enough to be at school, sorry, at the nursery. Smelling and leaks daily is more problematic, but there may well be a reason why she may well have sought advice, and if they've been seen and the child is generally well in themselves, then they probably don't need antibiotics. She's probably, I'm afraid, right, and it is a case of just waiting for it to clear up. Oh, she's waiting ear, nose, and throat. Lovely. So then I think I'm afraid you have got to just ride that. Possibly as a parent, I wouldn't necessarily want regular antibiotics either, because clearly they aren't, the whatever the cause is may well not be responding to antibiotics anyway. So you're giving the child a drug that they don't necessarily need. I think if they're seeking medical advice, then I'm afraid you've got to just ride it. Right, we're a little bit over time. By all means, anyone drop off that needs to. I'm just going to answer this last one. That I have a child that is 2.5 years old. After apnea, she's always warm. She said to us, can I have okay, so that's an interesting one. So child is 2.5, after a nap she's always warm, said to us, can I have Calpol now because I'm hot? I would agree that actually there's no reason why she needs it. What I would encourage that child to always have is say, no, the most important thing for you to have if you are hot is a cooled drink and is to keep your fluids up. Then if she's continually hot for the rest of the time, and you're actually recording a temperature, that might be different, but this child almost certainly, because they're under 5, they have quite a sensitive So their hypothalamus is quite sensitive. When they sleep, they do naturally rise their temperature. And actually now she just needs to cool back down, wake up and have a cool ice drink. But yes, I definitely wouldn't be giving Calpol for that because she's not asking it for. So what we talked about in the last session is that temperatures alone are not something that needs to be managed. It's the symptoms that come with it. So, is someone got a temperature and also just feels a bit rotten? Have someone got a temperature and a sore throat? Has someone got a temperature and a headache? It's the headache, the sore throat, the feeling just generally achy and unwell that you're treating with the Calpol. It's not the temperature itself. And that's a whole nother session.
Okay, thank you so much, everyone.
Thank you all for joining us.
Bye.